So I would like to call Dr. Trupti for her talk on PCR during emulsification and capsular exfoliations. Over to Dr.
This IC, I would be talking on PCR during phacoemulsification. For every cataract surgeon, happiness is to let the patient have an intact posterior capsule his entire life. So our happiness depends upon the intactness of this 4 micrometers or 4 microns posterior capsule. But most of the times the commonest complication which is encountered is a posterior capsular rupture, which may occur in 1 to 4% of the cases, but sometimes this incidence may be more. We should know what are the risk factors. Which cataracts are more prone to have a PCR during emulsification? So that we can anticipate the challenge, plan an intraoperative strategy and execute the plan. At the same time, we should have a backup plan in mind, like if a PCR occurs, what should be done. A thorough slit lamp examination and a thorough pre-op evaluation is of paramount importance. We have to see what is the type of cataract, whether it is a mature cataract, a intumescent cataract, if there is any zonular weakness or any phacodonosis, any fibrotic capsule, or if the cataract is of posterior polar type, or is there any pseudo-exfoliation, if the pupillary size is proper, whether the pupil is dilating or not, is the patient a high myope, or if it is a vitrectomized eye, then the chances of PCR will be more. Same is the case if there is any history of trauma. So now we know what are the challenges related to the type of cataract. The other factors are if our visibility is hazy, or if the instrumentation is not proper, we have not adjusted the microscope, or if it is a very anxious patient. In spite of this, if a PCR occurs during phacoemulsification, how to go about it? Here we can see that it is a posterior polar cataract and an oval rhexis has been fashioned out, and the emulsification has been started. At this point, here you can note that the PCR has been noted by the surgeon. It is a very scary situation for the surgeon because half of the nucleus is still there inside the bag, and the heartbeat starts increasing and we feel that this nucleus is going to drop down. So what should we do? The golden rule is just to stay calm and don't withdraw the phacoprobe from the eye. Just slightly manipulate. I have tried to manipulate the nucleus slightly at a superior plane, and without removing the phacoprobe out first, through the side port, we have injected viscoelastic substance so that the AC does not collapse. Now, if we want to phacoemulsify the remaining heminucleus, what can be done? Sometimes, many times as a surgeon, we feel that there should be something from inside which doesn't allow the nucleus to fall down. So what can come to the help? IOL scaffold is a very good technique for it. What is done here is that a 3-piece lens is implanted into the eye. The haptic of the 3-piece lens is placed over the iris. Now that the 3-piece lens or the scaffold is there in place, it is a very safe time now, so that we can do the emulsification of the nucleus, and this can be done at a slightly deeper plane also, protecting the endothelium, and using a low bottle height phaco, lower parameters, we can see that the chamber is stable and the phacoemulsification of the heminucleus was done. Here we have noted that the anterior hyaloid phase is intact when half of the heminucleus was still there in the eye and the PCR was noted. When we did the phacoemulsification with the scaffold in place, the vitreous phase was not disturbed. Rest of the cortical matter could be removed with using a dry aspiration, or you can use a eye cutter or a vitrectomy cutter with which you can remove. Ideally, we have to put triamcinolone acetate to find if there are any vitreous strands. This was not done in this case, but using a IOL scaffold, a PCR could be managed very well. The take-home message is that when PCR occurs during emulsification, using a IOL scaffold can provide a very safe technique. Thank you. Now the next I'm going to talk about pseudo exfoliation, which is a very commonly encountered clinical situation. In a cataract list, we can see that most common or majority of the cataracts have some amount of pseudo exfoliation, at least in the Indian population. This is an age-related degenerative change wherein there is deposit of fibrillar material over the iris and the anterior segment of the eye. This fibril is deposited in the form of rings over the anterior capsule, and this is a classical 3-ring sign which is seen with a clear zone in between the 2 rings. What happens is, because of the deposition of this fibrillar material in the zonules start becoming fragile. And the various enzymatic action occurs over the zonules, and because of it there is fragmentation of the zonules and at the ciliary body, which leads to zonular weakness, or it can lead to a progressive zonulopathy. In the back, the forces which are acting are, the zonular force is a centrifugal force along with the haptic, and the anterior capsular rim is a centripetal force. When we are operating a case of pseudo exfoliation, we should know what are the predisposing factors for the weak zonules. Like, each and every case of pseudo exfoliation will not have zonular weakness, but we should be able to anticipate. If the age is more, then chances of zonular weakness will be more. And the most important point to note is the ACD, or the anterior chamber depth. If there is a difference of anterior chamber depth in between the 2 eyes, or if the axial length is normal and the AC depth is less than 2.5, then always suspect that there is some zonulopathy in this eye. So there may be no phacodonesis, but when we start doing the capsulorhexis, we note that there is a zonular weakness. Denser the cataract, more chances of zonulopathy. At the same time, we can increase this zonulopathy also. A pupil size, noting the pupil size is also important. A smaller pupil size, a mid-dilated pupil, there is more chance of zonulopathy. What happens in pseudo exfoliation is, because of the weak zonules, you can see that the lens is moving anteriorly, the anterior chamber is shallow, and the pupil is mid-dilated. Here, this is a video in which we can see phacoemulsification is in progress. The pupil is well dilated, but while beginning the capsulotomy or beginning the rhexis, you could see that there were wrinkling of the capsule, so which indicates that there is some zonular weakness. The aim was to make a proper adequate sized at least 5.5 mm rhexis. The rhexis could be completed properly. A very gentle hydrodissection is done, and then the phacoemulsification is started. Here we have to note that all the maneuvers during nucleotomies should not increase the the zonular dehiscence. So slowly, and the forces should not act to increase the zonulopathy. When we want to remove the cortical matter, a tangential force is applied so that the zonular dehiscence or any does not increase. Here we have implanted a capsular tension ring because zonular weakness was noted. while implanting a capsular tension ring or a CTR ring, we start through the main port and slowly the CTR is dialed inside the bag. Once the CTR is in place, we can see that there is cortical matter which needs to be removed, and we can remove it slowly by using a tangential movement so that the zonules don't break. One more point which I would like to highlight for cases having pseudo exfoliation is the role of anterior capsular polishing. We have seen that most of the patients, when they come long term, they either have a dislocation of the capsular bag complex, or they have a contracted capsular anterior capsule or the capsular phimosis syndrome. We can prevent this by doing a proper polishing of the capsule by using curettes or diamond finishing. This will reduce the chances of capsular phimosis syndrome. So the issues which we need to deal with in pseudo exfoliation are the chances of PCR, nucleus drop, chances of corneal edema are more in the postoperative period. The IOP rise, secondary glaucoma also is there. There is prolonged AC reaction, and the long-term complications like capsular phimosis syndrome or late bag IOL complex dislocation can be there. Thank you for your attention.